Atrioventricular Junction. Anatomy of the atrioventricular (AV) junction. The normal AV junction can be divided into three distinct regions. 1. Transitional zone, the approaches, inputs, from the atrial myocardium to the AV node, composed of atrionodal cells. 2. Compact AV node, composed of nodal cells in its upper part, which appear to be responsible for major part of AV conduction delay, and nodal His cells in its lower part. 3. Penetrating part of the His bundle. The nodal, N, cells. The N cells are characterized by less negative resting membrane potential, low action potential amplitude, slow depolarization and repolarization, few gap junctions and intercalated discs, reduced excitability. Anatomy of the AV node. The compact AV node lies just beneath the right atrial endocardium, at the apex of the triangle of Cook, anterior to the coronary sinus ostium, and directly above the insertion of the septal tricuspid leaflet, where the tendon of Tadero merges with the central fibrous body. The triangle of Cook is the right atrial endocardial surface of the muscular atrioventricular septum, the septum which separates the right atrium from the left ventricle. This triangle is bounded by the tendon of Tadero anteriorly, septal tricuspid leaflet inferiorly, and coronary sinus mouth posteriorly. Anatomy of the His bundle. The penetrating portion of the His bundle penetrates the central fibrous body, slightly anterior and superior to the AV node, then emerges as the non-branching portion. Within 1 to 2 cm, it divides into the right and left bundle branches, at the upper border of the muscular ventricular septum. Cells of the proximal part of the His bundle resemble those of the compact AV node, while distal cells resemble those of bundle branches. Atrial inputs to the AV node. Atrial depolarization spreads in fibers that funnel into the compact AV node via discrete inputs, approaches. 1. Posterior approaches closer to the coronary sinus ostium, thought to represent the slow, alpha, pathway. 2. Anterior approaches closer to the apex of the triangle of Cook, thought to represent the fast, beta, pathway. 3. Middle approaches, connecting the atrial septum and the left atrium with the AV node. The slow and fast pathways are named after their conductivity. The slow, alpha, pathway has slower conduction, but faster recovery, due to shorter refractory period. The fast, beta, pathway, on the other hand, has faster conduction but slower recovery, due to longer refractory period. The reasons for these differential characteristics are unknown. Dual AV node physiology. Presence of dual, or even multiple, AV node pathways provides the natural anatomical substrate for the occurrence of AV node reentry. Dual AV node physiology, however, is present only in about 25% of people, thus the anatomical substrate does not inevitably result in dual physiology. This is easily understood, since for reentry to occur, many requirements should be fulfilled: anatomical substrate, central area of block with enough tissue mass, around which the impulse can circulate, effective refractory period in the beta pathway long enough to cause unidirectional block, conduction time in the alpha pathway longer enough than the refractory period of the beta pathway, and usually a trigger is also required. Furthermore, although dual AV node physiology is present in about 25%, AVNRT is only present in about 1 in 1,000, 0.1%, of the general population. Whether the reentry circuit of the atrioventricular node reentrant tachycardia, AVNRT, is confined to the compact AV node, or involves a component of atrial myocardium, is still controversial. The ventricular tissue, on the other hand, is not involved in the AVNRT circuit. The commonest paroxysmal SVT is atrioventricular node reentrant tachycardia, AVNRT. Overall, it constitutes about 60% of cases. The relative prevalence, however, differs in different age groups. In children, atrioventricular reentrant tachycardia, AVRT, is more common, while it is the least prevalent in older ages. Atria tachycardia, AT, increases with advancing age. Classification of regular narrow QRS complex tachycardia. For diagnostic purposes, the regular narrow complex tachycardia, NCT, is classified according to the relative duration of the ECG RP and PR intervals, or equally the relative duration of VA and AV intervals in electrophysiological studies, EPS. Short RP or short VA tachycardia implies that the RP interval is shorter than the PR interval, and VA is shorter than AV. Long RP or long VA tachycardia implies that the RP interval is longer than the PR, and VA is longer than AV. RP interval is measured from the start of QRS to the start of P, while PR interval is measured from the start of P to the start of QRS. Short RP tachycardia is also called slow-fast tachycardia, because the anterograde atrioventricular, AV, conduction, measured as the PR interval, proceeds in the slow, alpha, pathway, while the retrograde ventriculotrial, VA, conduction, measured as the RP interval, proceeds in the fast, beta, pathway. The fast retrograde conduction explains the shorter RP interval. Long RP tachycardia is also called fast-slow tachycardia, because the anterograde, AV, conduction, PR interval, proceeds in the fast pathway, while the retrograde, VA, conduction, RP interval, proceeds in the slow pathway. The slow retrograde conduction explains the longer RP interval. Narrow complex tachycardia is classified based on RP, not PR, probably because in AVNRT and AVRT, ventricular activation, QRS, occurs first, followed by atrial activation, P, that is, RP is followed by PR. Based on RP, or VA, the differential diagnosis of regular narrow complex tachycardia is as follows. Short RP, short VA, tachycardia. 1. Typical AVNRT. 2. Orthodromic AVRT. 3. Atrial tachycardia. Long RP, long VA, tachycardia. 1. Atypical AVNRT. 2. Orthodromic AVRT with slowly conducting bypass tract. 3. Atrial tachycardia. 4. All forms of sinus tachycardia. Paroxysmal SVT most often occur in normal hearts. They are not life-threatening and are typically treated for symptoms. Catheter ablation is successful in greater than 90% of cases. Thank you.